Welcome everybody. My name is Gary Morrison and I'm the co-chair of the Shine a Light support group for prostate cancer and other cancers. I'd like to welcome you to the final webinar for our series this year in 2022. The topic this time is Prostate Cancer 101, and I'm absolutely delighted to welcome Professor Philip Stricker, who has come back to join us to be the sole presenter here to give us updates in relation to prostate cancer. I'm going to leave it to Kalli Spencer, my co-chair, to introduce Phil more formally. I would like to start the whole session by doing a welcome to country. On behalf of all of you gathered here today, I would like to commence the meeting by acknowledging the First Peoples, the traditional custodians of the countries where we are all located. Each of the nations that we'll be representing here has faithfully cared for the country for thousands of years. I would also like to respectfully acknowledge our elders, past and present, and remember that they have passed on their wisdom to us in various ways. Let us hold in trust as we work and serve our community. To you all, welcome, good morning, good afternoon, right throughout Australia, New Zealand and parts of Asia. Today, as I said, our topic is on Prostate Cancer 101 updates. And without any further ado, I'd like to hand over to my co-chair, Kalli Spencer, who will introduce Philip Stricker.
Thank you, Gary, and good to see everyone again. So we're very privileged and honoured to have Professor Philip Stricker, who's a urological surgeon and prostate cancer specialist, coming from St. Vincent's Prostate Cancer Centre in Sydney. He leads numerous clinical and research institutes. He's responsible for training the future urologists and scientists of Australia. And he truly is at the forefront of the field and recognised as an expert locally and internationally. And if you want to read more, you can read through the biography in the email. Today, he's going to go through, really, as Gary said, updates. What has changed? What's new in the world of prostate cancer? Yeah, and as usual, we want you to please ask as many questions as you would like about prostate cancer in the Q&A, which is you can find at the panel at the bottom of your screen. And you just click on that and you'll have an option, and you can even post anonymously if you don't want your name to be shared. So yeah, please do, and I will pose those questions to Professor Stricker as we go, or at the end of the session. So keep them coming. It is a fairly long session, so yep, just hang in there and we'll engage you as much as we can. And over to you, Professor Stricker.
Thanks very much, Gary and Dr. Kalli. It's a great privilege to come back again, and it's a little bit of a daunting task to try and cover the whole area of prostate cancer. Recently, Professor Wu and myself gave a similar talk to the GPs of Australia at North Shore, and so he very kindly agreed to share some of his slides with me as well, so I acknowledge the support that Henry's given me. I'm broadly going to break this up into two parts. The first part is going to be the diagnosis and investigation, and the second part's going to be treatment and complications. And I feel it would be much better to be able to ask questions as we go, because I think that you'll probably find you'll forget your questions by the end of the session, which is the last thing I want you to do. And I've given us enough time to ask questions as we go, because it really, the aim of this is an interactive session between the people who really care and matter, the people who actually have the condition. So I think the first thing to talk about is PSA testing. it's been a very long and tortuous story, PSA testing. When it first came in 1988, it was a revolution, and then they realized it caused overdiagnosis. And now with more modern imaging techniques and a better intelligent use of the test, it's become a much better test. So the Urological Society of Australia does not recommend using what's called mass screening, in other words, testing every person without information. What they recommend is testing people between the ages of 55 to 69 after providing information about the risks and benefits of such testing. And that was only updated in 2020. In America, they have different rules, and the key organization that gives advice about PSA testing is the US Preventative Services Task Force. And they recently changed their recommendation from a D, which was do not screen for prostate cancer, to C, which is the decision is to be screened for prostate cancer should be an individual one. And I think they're starting to recognize that the data now that is coming in supports informed screening. Now, the National Clinical Practice Guidelines, which was put out now 7 years ago, was a collaborative work from the Prostate Cancer Foundation of Australia and many other organisations, and you can see the references to all those. But the recommendation ultimately was to offer evidence-based decisional support to men considering whether or not to be screened. So
Phil,
yes.
Sorry to interrupt. I don't think your screen sharing. You might want to check that.
So what we were saying before was that the recommendation internationally at the moment is to really give people informed information about whether to be tested or not. One of the big problems that we've got at the moment is that the Royal Australian College of Surgeons, of GPs, have recommended not to test, which is quite a remarkable thing considering they are the gatekeepers of prostate cancer testing. And screening, they said, of asymptomatic low-risk men is not recommended because the benefits have not been shown to outweigh the harms. But when you look at the references that underpin this recommendation, they are profoundly outdated. And there is not a single reference which is recent that has actually been added since 2014. So the Urological Society, the Prostate Cancer Foundation of Australia, we're all speaking with the Royal Australian College of GPs to try and update their recommendation, because general practitioners who actually see patients and who are confused about what to do, if they're influenced by their book of recommendations, will say they don't recommend it, which of course is way out of keeping with the current recommendations worldwide. So therefore, just to review those current guidelines, the Urological Society of Australia, the US Preventative Services Task Force recommend that there should be an informed decision, whereas the Royal Australian College of GPs, which is out of date, does not recommend it at all. So what should you do? I think you should follow the majority guidelines and offer PSA testing if patients are agreeable after appropriate discussion. And I think the evidence is very strong that if PSA is used intelligently, lives are saved. So PSA in general practice now is not used as just, let's do a PSA test, and if the PSA test is elevated, let's do a biopsy. We have to think about using PSA intelligently. It's not a diagnostic test for prostate cancer. That's what a biopsy is. So really, we have to think of PSA as a risk assessment tool. If it's up above the normal range, and if it's shown on repeat to be elevated, then there's something wrong with your prostate. It might be cancer, it might be enlargement, or it might be inflammation. And it's really up to that general practitioner and the patient to work out exactly what it is. We also have to...
Sorry,
Yep.
just to go back, someone was saying about USAN's recommending starting at the age of 40 with if there's a family history, and 50 if none. And they also agreed with your sentiments about the Royal College of GPs, and that they aren't interested in the men's health, and it's quite deplorable.
Look, I'd have to agree with his sentiment about the Royal Australian College of GPs, and many intelligent GPs also agree that it's deplorable that it hasn't been updated in a decade. But in terms of the family history story, I haven't gone into enormous amount of detail, but you are 100% correct. If you have now I'm going to emphasize the word strong family history, you should start from the age of 40. But if your father, at the age of 75, because of an elevated PSA, was noted to have a low-grade tumor, that is not a significant family history. But a significant family history is that's when a younger person gets diagnosed with a high-grade cancer in your family. That's a significant family history. And then you should start from the age of 40. You're absolutely correct.
Yeah.
So let me continue then. So I think the next thing to do is think of the PSA as a risk assessment tool. So say this person's PSA is 3.1, then most elevations are not due to cancer, they're due to inflammation. And so it's important that maybe an ultrasound of the prostate's done, maybe an MRI, maybe a history, maybe trying to find out what the person was doing in the 2 days before getting the PSA test. So it needs to be looked at intelligently. And then we need to consider adding extra tools and not just an isolated reading. For example, there's a thing called the free to total PSA ratio, which looks at the different components of it. If the ratio is below 10%, you have a 50% chance of having cancer. Whereas if the ratio is greater than 25%, you've got a less than 10% chance of having cancer. So that really helps. PSA velocity, if we measure our PSA every year and look at how it changes over time, that's way more accurate than having an isolated PSA reading. And finally, PSA density, which sort of tries to work out whether the PSA is commensurate with the size of your prostate. And if it is, then we worry less. And if it isn't, we worry more. That concept is PSA density. And if the PSA on top of the size of the prostate is less than 0.15, we are more, is greater than 0.15, we are more concerned that you have a cancer. In other words, the PSA can't be explained by the size of the prostate alone. So this is just some information about how the free to total PSA ratio impacts the likely diagnosis of cancer. And this is how the PSA velocity, if it goes up too fast, for example, looking at the fourth line, at higher PSA levels, if the PSA goes up by more than 0.75 per year, it raises a red flag. One of the important things to also realize is that chopping and changing laboratories is really bad news. If you chop and change laboratories, they're all using different assays now, and you'll go into complete confusion as to whether it's going up or down or sideways. So always try and use the same laboratory and the same assay. PSA density, as what I said before, 0.15 seems to be the magic cutoff. And then finally, to use PSA intelligently, we have to consider it with other factors, such as family history, such as a recent infection, such as recent ejaculation. If you ejaculate within 48 hours of having a PSA test, it goes up. Recent long-distance bike riding. If you've had prostate manipulation for whatever reason, the pattern of PSA behavior, if it goes up and down suddenly, that's not a cancer, that's a benign condition. And recent operations. And then finally, I have quite a few people who are on tablets which affect PSA. For example, hair loss medication in the form of finasteride, even used at low dosage, such as 1 milligram, can halve your PSA level. So you need to be aware of what people are actually on. So as you can see, PSA alone is not the answer. It's an intelligent use of PSA.
Phil, just to go back to risk factors there and family history, Anne, who's CEO of PCFA, had pointed out that one direct male relative impacted leads to double the risk of diagnosis, and 2 or more direct males in your family impacted leads to a 5-fold increase in risk. I'm sure that's based off some stats and research that they've done.
And again, I 100% agree, but with the caveat that the risk factors of father and brother, for example, too, are high risk cancers, not the cancers that we just pick up at 75 with Gleason 6. So if you've got 2 high risk cancers in the family, such as a brother and a father, then you have a 5 times increased risk of having prostate cancer. And if there's only 1, it's a 2 times risk. And that's 100% correct, and that's based on very sound data.
Thank you.
That's good comments, because it sort of adds to what I'm saying. And again, here we are, we're now looking at other things with regard to family history. For example, different genes. For example, the BRCA gene, which is just one of many genes, is if you have this gene, and it tends to occur in certain predominantly Jewish families, it increases the risk of prostate cancer significantly, means you need to start a bit earlier, and also it becomes much more aggressive at an earlier stage, so you're much less likely to adopt an active surveillance policy if you have one of these genes. And increasingly, men with strong family history of prostate cancer go to genetic specialists now. The one that we use at St. Vincent's, his name is Professor Spiegelman, and he'll run a test of 18 genes, which will increase the risk enormously of having prostate cancer.
Can I ask a question? Is it all Jewish people, or is it Ashkenazi Jews specifically?
Ashkenazi Jews specifically. Yeah, no, it's not all Jewish people. And it's certainly, I've seen many BRCA genes in other families, but I suppose in the eastern suburbs of Sydney where I practice, the majority of people with BRCA positive Ashkenazi Jewish people.
Thank you.
Now, infection is a potent cause of an elevated PSA. So if you've recently had burning or scalding passing urine, and it's hard to stop going to the toilet, and 2 weeks before you were fine, and then you do a PSA at that time and it's elevated, well, it's almost certainly going to be due to prostatitis. So listening to the story is very important. Now, the track record of PSA fluctuation can be quite reassuring. For example, if you know, I have many patients who I've been looking after and monitoring for 10 years or 20 years. And if I see that their PSA sits at around 3, and then suddenly it rises to 10, And then within a few weeks, it's back down to 4, and then another few weeks back down to 3. And it's done that several times over the last 10 years. You know that the next time it goes to 10, it's probably not going to be a cancer, it's going to be a prostatitis. So that also helps. Whenever you do a TUR, like shaving away the central part of the prostate, which produces most of the PSA, and whenever you take drugs which shrink down the prostate, mainly the central part of the prostate, such as finasteride or dutasteride, the PSA levels will decrease. What's important in this group of people who are on these medications is that a rise whilst on these medications is a very serious problem, because it really only can be coming from cancer unless there's an infection. And so we take a rise when people are on these medications or have previously had a TURP as more serious. Now, in the past, as I said before, it was PSA, elevated, urologist, biopsy. That's no longer the standard of care. And this is changing all the time. People were referred, but these days there is an MRI between the PSA and the biopsy. In fact, if the MRI prior to the biopsy is normal, then there's no need for any biopsy because unless there are other risk factors. And those other risk factors might be the PSA density is really high, even though the MRI doesn't show anything. And maybe that person's got a family history. So there may be other extenuating circumstances that may drive you or drive the urologist to say, look, even though the PSA, the MRI is okay, I think we should do a biopsy. But the MRI has saved many, many patients unnecessary biopsies. And it now is covered by Medicare, and it only requires 2 elevated PSA tests to be covered by Medicare. There are obviously some MRI non-compatible implants like pacemakers or pieces of metal in the brain, which may make MRI not possible, but 99.9% of patients are suitable for an MRI, even with hip replacements or bits of metal in parts of their body. So the role of MRI for prostate cancer is a key role in diagnosing clinically significant cancers. It's also used for finding out how extensive they are, and it's also used for monitoring cancers called active surveillance. Now, the item numbers for Medicare means that you have to comply with the item numbers to avoid the $600 or so which you have to pay for an MRI. And for under 70 years of age, you really just have to have 2 PSAs above 3, and the free to total ratio should be below 25%, or any PSA above 5.5. And for men above 70, then for those people, their PSA should be above 5.5, and again, with the free to total ratio below 25%. Now, it requires the specialist, the urologist, or the radiotherapist to order the MRI, not the GP. Once surveillance scan is permitted every 3 years, so once you've been diagnosed with a low-grade cancer, you're allowed to get an MRI for free every 3 years. And this is a little bit of a very famous study in the urological literature called the Precision study. And ultimately, just to explain it to you, MRI was shown to diagnose, using MRI and just targeting the area, was shown to increase the number of cancers picked up and decrease the number of insignificant or Gleason 6 tumors picked up, which are more nuisance than benefit. So it was a major step forward in the whole management, and the findings have helped at both ends of the spectrum. One, to avoid people getting unnecessary biopsy when the PSA is elevated and the MRI is normal. And two, on the other end of the spectrum, where the PSAs are very high, and the MRI can give a lot of information about the extent of cancer and guide treatment. Now, the biopsy has also taken a bit of a revolution. In the old days, we used to do transrectal biopsy, and worldwide, over 50% of people are still doing it this way. I'm largely credited for bringing in a technique called the transperineal biopsy, and even had the privilege of writing up the definitive chapter in the urological textbook worldwide called Hinman's on this. And the reason I changed was because of patients who complained of pain, patients who got infections, bringing them to intensive care, and also the difficulty in accessing certain parts of the prostate with the transrectal approach. As a joke, we called it transfecal, and you can see why. With increasingly resistant bacteria coming in worldwide, and with increasing expense of being in intensive care to treat these, we really needed not just to make more potent antibiotics, but change our technique. And that brought about the transperineal technique, which goes through clean skin behind the scrotum. And the problem with it has been that there was expensive equipment. You needed to do it in operating theatre with GA, and it was long procedure time, which was poorly remunerated. All of those have been addressed now. So it no longer has expensive equipment. It's simple. It can be performed in an ambulatory setting under local if necessary. And the latest MBS has created specific item numbers for it, and it's well remunerated. So all those have been addressed now. Now, once you diagnose prostate cancer...
I wanted to interrupt. Do you know if anyone's still doing transrectal, or is it all transperineal now in this country?
I think in Australia, there are the occasional person who does transrectal, but I think as an informed patient now, if a person said he's going to do transrectal, I would actually change urologist now. I think it's got to the stage that transperineal is standard of care. Having said that, it's not the standard of care in America because the health system financially remunerates outpatient testing in the office much better and makes it almost impossible to do it in theatre. So there it's been a very slow progress and it hasn't really come on. But I recently did a tour of the States teaching them about focal therapy, which we're going to talk about soon. And in that particular going around the country, if you do focal therapy, you have to do transperineal because otherwise you don't get an adequate mapping of the cancer. So I think it's a slow process worldwide and the whole system has to change and infrastructure has to change, as I showed in the other slide, but it is changing.
Here's another question. Is there still a role for the digital rectal exam for assessing the state of the prostate? Someone in the group was actually diagnosed in that fashion. What's your opinion there?
I strongly support digital rectal examination with the caveat of saying by an experienced person. So an experienced person is an experienced GP or a specialist, people who understand what they're looking for, and if they find it, know what the significance is. We know that in experienced hands, an abnormal rectal examination, which picks up a hard lump, is highly accurate and sometimes cancers that form a lump don't make much PSA and so can't be picked up early in any other way. So I strongly recommend it. But if you have a 30-year-old GP, and if you read the Royal Australian College of GPs book and you look at the evidence worldwide, it says that digital rectal examination is not an evidence-based thing. Well, it probably isn't for that doctor, but it is for experienced practitioners. So I hope that answers the question.
It does, and I agree.
As far as staging goes, one of the big other changes that's occurred in prostate cancer is PSMA PET scanning. Now, once you've got diagnosed with a prostate cancer, a significant one, Gleason 7 or above, then the next step is to do testing to find out how far it's spread afield. The traditional testing is a bone scan and CT scan, and that has now been replaced, certainly in Australia, by PSMA PET scanning. Once again, America is way behind the 8 ball. They've only introduced it in the last year or two. It's far from the standard of care. And even in parts of Europe, it's only becoming accessible now. In Australia, and I was privileged to work with Louise Emmett, and where we did the original, one of the original definitive trials called Primary 1, which looked at the role of PSMA PET scan, not only in the assessment of spread, but also in the assessment of the primary tumour. But here we're talking about spread. That has been, we've now used PSMA PET scanning almost exclusively for spread without bone scans and CAT scans for almost a decade. And I wouldn't even think of using anything else. And the good thing is it's now even rebated by the federal government as of the 1st of July 2022. I will make one comment, however. Some clinical trials were designed in America or Europe or before the PSMA PET scan was in. And so to get into some clinical trials, you actually have to have a conventional bone scan, CT scan to get into them. That gradually will change, but for the moment, that's still sometimes an issue. If we then move to treatment. So what we're talking about now is prostate cancer, localized prostate cancer, not prostate cancer that's spread all over the place, but localized. And we're now talking about what options of treatment do we have? And there are a lot of treatments now. Obviously, there's removal of the prostate, either by the open laparoscopic or robotic route. There's low dose rate brachytherapy. There's radiotherapy in all its different forms. There's high dose rate brachytherapy, active surveillance. And the most recent addition to this group is focal therapy, where you only treat part of the prostate, almost like the prostate lumpectomy. When we talk about how do you choose which treatment, there are many factors that impact that. And obviously, the nature of the tumour and the extent of the tumour is critical. Some of the prostate factors, such as size and urinary symptoms and previous TURP, are critical. Local factors, such as whether there is other conditions in the pelvis, such as a fractured pelvis, ulcerative colitis, which would make radiotherapy untenable, previous surgery in the pelvis, previous radiotherapy there. Patient factors, you know, what's the priority patients put on, for example, incontinence or sexual function or rectal damage in their particular decision-making process. And then, of course, there's institutional factors such as what expertise that does the institution that you're going to have? Are they better at open surgery than robotic? Are they better at radiotherapy than surgery? And so you have to take that into consideration, obviously, particularly if moving to other centres is not an option. Individualising the treatment is now a standard of care. So having a prostate nurse, which the PCFA have embraced, I'm privileged enough to have my own personal prostate nurse of 30 years, Jane, and they will speak for hours to patients, helping them make decisions about which treatment they're going to have. Having a multidisciplinary clinic where there are radiation oncologists, medical oncologists, and urologists all feeding in can be very necessary in complex cases. And finally, having even a sexual health physician to be able to discuss what options there are if the treatment causes impotence, and understanding that before the treatment can be also important. And all these things take time and need to be worked through slowly. I think it's also very important to realise that for low-risk patients, Gleason 6, whilst 30 years ago or 20 years ago, we used to think they needed treatment, we're now absolutely convinced they don't need treatment. And this was the subject of a very large trial called the Protect trial, which showed that the death rate from active surveillance surgery or radiotherapy was exactly the same for Gleason 6 tumours. In fact, the death rate was lower if you had active surveillance for Gleason 6 tumours than surgery and radiotherapy. Now, a lot of the discussions also come in about surgery versus radiotherapy. You know, is surgery the right treatment? Is radiotherapy the right treatment for a particular condition? There have been trials looking at this, and the conclusion from these trials was that there is a higher chance of incontinence with surgery. There's a higher chance of frequency and urgency with radiotherapy. There's a higher chance of bowel problems with radiotherapy than surgery, even though that's improving. And sexual function is best with brachytherapy and external beam therapy than surgery in general. But over time, in expert units, the surgery potency rates improve. So the potential benefits of surgery over radiotherapy in general terms, and again, this is such an individual thing, is that if you have urinary symptoms as well, then that favours surgery. Surgery is better for the younger patient because it leaves radiotherapy open for salvage, whereas if you have radiotherapy early, surgery is a much more difficult salvage option. Surgery does not cause radio recurrent disease. Well, I'm sorry, what I'm really saying here is that if cancer comes back after radiation, it's hard to treat. Obviously, if you've had surgery, then that's not an issue. The other issue with surgery is that it doesn't cause cancer in 10 to 15 years' time. There is a slight increase in rectal cancer and bladder cancer after radiotherapy, and that's not the case with surgery. Furthermore, with surgery, you get immediate pathology information, which tells you about whether the cancer has spread early and whether you need further treatments. And long-term problems seem to be less with surgery than radiotherapy.
And I wanted to say, isn't the monitoring and surveillance in terms of PSA monitoring better also with surgery than radiation, considering PSA bounces and that sort of thing?
Yes, I think that would be a reasonable additional point. But there are benefits of radiotherapy. Obviously, it's less invasive, there's less incontinence, it's better for certain tumours. For example, if you have an extensive cancer at the apex of the prostate or under the trigone of the prostate, it's very hard to completely eradicate that surgically. And if you do it, or if you try it surgically, then what you're dooming the patient to is both a combination of surgery and radiotherapy. And For some people with morbid obesity, massive adhesions, unfit patients, a previous fractured pelvis, radiotherapy clearly has an advantage. Now, I'm not trying to tell you how to go between surgery and radiotherapy, but what I am saying is that it's always worthwhile getting a radiotherapy and surgery opinion before a final decision's made. For many reasons, but the most important is because it decreases the amount of regret that could occur after a treatment if a side effect occurs. Active surveillance is really what we do instead of treating cancers, and it's mainly for Gleason 6 and some small volume Gleason 7 tumours. We found that these tumours are indolent. If your consultant tries to scare you with the cancer word, then I'd find another consultant, because scaring a person with a Gleason 6 tumour into having surgery is something that should never happen. We need to be sure that you've had a thorough evaluation, that something hasn't been missed. And with modern day transperineal biopsy and MRIs, that's rare. We need to monitor these people with MRIs, PSAs, and the occasional biopsy. And sometimes people use genetic markers to help decide whether you've got a good or bad Gleason 6 tumour.
Can I ask you something? Just going back to the point of getting a radiation oncology opinion. I know in the public sector, we couldn't operate until the patient had that. It was almost compulsory. Is there such a ruling around that, or is it per institution?
I think the New South Wales Cancer Institute recommend presenting every case at the MDT meeting. That's obviously impossible just through numbers. So I think if something's presented at an MDT meeting where radiation oncologists and urologists are there, I think that's fine. It's important that the information from that meeting is imparted accurately to the patient. But in general terms, I think that getting an opinion from both is important, because I'm a little bit unusual that I get heavily involved in the radiation oncology work as well as surgery. So I don't have many biases, but most surgeons have a bias to surgery and most radiation oncologists have a bias to radiotherapy. So I think it's, patients are clever people, and I think they can see the biases, but then think about themselves as what fits better with their particular circumstance.
Yeah, as someone else has mentioned here, why isn't it compulsory for GPs to refer a prostate cancer patient to a radiation oncologist as well as a urologist, protecting patients from urologists who only want to operate?
Well, I think that the urologists are still the gatekeeper of the prostate. So they interpret the PSAs correctly, they interpret the MRIs correctly, they do the biopsies, and the radiation oncologists don't do that. But once the person has been diagnosed with a prostate cancer, I think it's important, and an important GP role, to ensure that a balanced opinion's being given. And I think it's totally reasonable for either a patient or a GP to insist on a radiotherapy opinion.
Yeah, I agree. And just a point on active surveillance, we see lots of people in the support group, there's a lot of anxiety around waiting for those results and getting the biopsies done and scans. How do you get around some of that anxiety around being on active surveillance?
I think it's a matter of how well the specialist communicates with the patient. As I said before, and I use the term, don't scare the patient with the cancer word. If I told people they had a tumour of low biological activity and never used the cancer word, then the patient wouldn't be anxious. So I think it's imparting some data about what a Gleason 6 tumour does. And the 5 pieces of data I give patients is: 1, I tell them that in 20-year follow-up, if you do nothing, you've only got a 2% chance of dying of prostate cancer. That's if you do nothing. 2, only 20% of people with a thorough initial evaluation need treatment at any stage. And when they have that treatment, they're just as curable as they were at the initial time. 3, if you look at the genetics of Gleason 6 tumours, they look like the genetics of normal tissue, not cancer. 4, the word cancer is being debated at high levels, and a lot of people say we shouldn't use that word anymore in a Gleason 6 tumour. And 5, if you look at the original radical prostatectomies done for Gleason 6 tumours, there is not a single world case of a tumour from Gleason 6 ever having spread. Now, when I explain that to a patient and they understand they've had a thorough evaluation, so they haven't missed something, then none of my patients get anxious unless they have an anxiety disorder. If they have an anxiety disorder and patients know they have that, then I focus on their anxiety disorder. There are the very rare patients who are so anxious that you simply have to do treatment. But, you know, I would take one Gleason 6 tumour out per year out of hundreds. So it's a rare patient who I'll do that.
I really like your rule, Stricker's rule of 5. That's great. That's really, really good.
Yeah, so that's just, and that's all factual, and I can back it up with papers and facts.
Yeah. 2 other questions while we're here. I mean, do you see a role for the Prostate Cancer Support Group in supporting men with their diagnosis and their future treatments?
100%. I mean, the support group, as you well know, the first support group was set up by Max Gardner and myself and Jane Matthews at St. Vincent's in 1992. So 30 years ago now. And that we taught all the other support groups. And one of the key reasons for setting it up was to do with supporting men through their journey and making sure they didn't make any mistakes and didn't have any regret. So anything that leads to that outcome is in the benefit of the patient. So a second opinion is in the benefit of the patient. You know, explaining that having a biopsy every year on an active surveillance sounds bloody excessive. Why don't you just talk to your specialist or get another opinion? You know, all that type of thing I think is critical.
Yeah. I think sometimes urologists don't want to send their patients to support groups in case they go choose another specialist.
Well, I think if you have that anxiety, then maybe you're not being open and honest with your patient. And I think then the motivation behind the consultation, comes into question.
Yeah. Sorry, we're going off sidetrack here, but I suppose while we've got the questions, let's answer them. Someone else wanted to know about the training of prostate cancer specialists and nurses. Is it done centrally? Is it done at the nursing school? Is it done by you, the urologist, in your center or hospital where they work?
So my own nurse was trained by me, and but the Prostate Cancer Foundation initiative to have nurses, they are trained by a constellation of different means. Initially they had urologists and radiation oncologists involved, but it was trained by the Nursing Institute. And there's a formal program which they go through, and there's also a period of monitoring. If the head of the PCFA is on the line at the moment, I think you said, well, not the head, but a representative from PCFA, they may wish to correct me.
Yeah, we could find out about that. There's one other question about grade 2 Gleason 3+4, and maybe you're going to still talk about this because you've only been speaking about Gleason 6 and active surveillance, but maybe you're going to tell us a bit about the stats for Gleason 7.
Yeah, look, there is a funny group that I call the grey zone. The grey zone are not obvious active surveillance, but not obvious treatment. And the grey zone, let me just see if I've got, yeah, here we are. So I'll skip this slide when we get to it afterwards. But if you have a look on the left-hand side, the obvious active surveillance ones are Gleason 6, not too extensive, MRI looks okay, and the PSA density is okay. The obvious ones for treatment are people with a Gleason 7 tumour where you've got greater than 10% Gleason 4 pattern, or certainly greater than 20%. The grey zone is where you've got a lot of Gleason 6, a person with Gleason 6 in the under 50-year-old age group, a Gleason 7 with less than 10% Gleason 4 pattern, and a person who's got a tumour, but the MRI looks like it's there's more there, that you may have undersampled it, so it's got a PIRAD 4 or 5, suggesting that maybe you've undersampled that area. And finally, a high PSA density. So that group in the grey zone are people who need to have a more detailed discussion with the urologist about the merits of active surveillance. So in terms of your specific question of Gleason 3+4, what's the death rate of them over a 20-year period? And obviously we can only give a 10-year period in this situation, because a 20-year period, they haven't been doing it for 20 years with Gleason 7. There's about a 5 to 10% death rate at 10 years untreated.
Phil, we actually have the CEO of PCFA, and she can speak to how those specialist nurses are trained. Should we give her a minute to talk, and that will give you a little breather?
Yeah, okay.
Yeah.
No problems.
Okay, and I've given you, you can just unmute yourself and speak.
Hi, Kelly. Thank you. Thanks for inviting me. Just to clarify, look, PCFA trains and manages all PCFA prostate cancer specialist nurses. So that work is led by Sally Sara, who herself is a nurse of 30 years and an expert in all aspects of prostate cancer. We have a dedicated practice framework and competency standards, and all of that is very stringently monitored and regulated. We also support the nurses throughout the year with training and professional development. The teams meet weekly and monthly on a rotation. We have now more than 100 nurses around the country, as well as a dedicated telenursing service set up at different office locations around Australia. So people can call us anytime on 1800. It's now a fully integrated service along with a cancer counselling service, and we welcome people's questions and calls. There's been so much great information covered by Philip today, and we know that there's a lot of work for us to do in this space. We're just commencing now the review of the current PSA guidelines, and we can't wait to work with our support network to deliver new guidelines and really improve outcomes for everybody.
Thank you so much, and it's like a little advert, a TV advert. We're so lucky to have you on the line, and thanks for that insight. That's really helpful, and I think it answers the questions of our participants. Thank you. And back over to you, Phil.
Thanks. So if I go, hold on. Where was I? And so you were asking about the dangers of Gleason 7. So maybe a 5% chance of death rate untreated at 10 years. So again, it gives people a perspective. And so, you know, the one thing it does immediately is make sure they don't feel rushed into a decision. And I think rushing decisions, which is sometimes people's emotional reaction, almost coming from their amygdala rather than from their cerebral cortex, is a sort of a gut reaction to hearing the word cancer.
I can appreciate that neuroanatomy that you just mentioned there.
Look, I'm happy to go into that in more detail, but I'm just reading a book about trauma and stress, and I'm writing a book at the moment about patient-doctor communication, which hopefully will be done by the end of next year, and it's called Avoiding Regret, Talking to Your Doctor. And so it'll be exactly addressing some of these concerns about how people talk about things. With regard to Gleason 7 tumours, low volume Gleason 7 tumours, the really good ones behave very similar to a Gleason 6, and the not so good ones behave more like another tumour, but they're still not a rapidly progressive tumour. So, you know, everybody's circumstance is different. When they learn about the risk that's posed in a realistic way and know that for the next 2 years, they're safe to monitor it and possibly longer, then if they've just formed a new relationship and that's a really important thing to them and they want to consolidate that, or if, you know, a child is really important, or some particular extenuating circumstance, they've been through some terrible trauma and the last thing they could deal with is another operative trauma in their life at the moment, then delay is highly appropriate. And it needs to be individualized to the person's consideration. Obviously, that may not be the case with a Gleason 8, 9 or 10 tumour, but certainly it is the case with a Gleason 7. Does that answer the question?
Yes, it does. Thanks.
So this was the original study. Now it's 12 years old by Laurie Klotz, who's a friend of mine from Canada. And what it showed was that if you look at I'm just going to try and get the screen. Are you seeing all my other things on my screen?
Just your PowerPoint presentation only.
Okay, good. So if you look on the right screen, you'll see a blue line going upwards, and that's the death rate on people on active surveillance. And then a bottom tiny yellow one, which is almost not moving from the baseline, which is the death rate from prostate cancer. And that's the story with Gleason 6. You know, half of them by 10 or 12 years are dead from natural causes, but almost nobody from prostate cancer. And this is just an illustration of a patient who is on active surveillance, and I'm highlighting the use of MRI now. This is a guy who I've been monitoring for some time. You can see on the yellow line from the age of 60 years of age. And, you know, he had this and that and a biopsy and had a tablet with Avodart, and then he stopped the Avodart and all sorts of things. But if you have a look on the left side, there's a little black spot with an arrow on it, and it's tiny. And that black spot was a new Gleason 9 tumour. So it's really important in active surveillance to do periodic MRIs. We recently published in the American Journal of Urology the results of that, and it showed very clearly that MRI is now integral to monitoring in active surveillance. And adding genomics, which is not supported financially in Australia, what this involves is taking the tissue that you've taken out of the body, looking at the tumour and asking him to analyse the genomics of that tiny bit of cancerous tissue, Gleason 3+3 or 3+4. The reason for doing it is to say whether it's a good cancer or a bad cancer. And financially, it's supported over in the United States, and there are a number of different agents there. But it's not supported here, and unfortunately it's about $5,000 to have it done, but it's free in the States. I personally don't have a lot of time for this. I think you get enough information from all the information we've got, so I wouldn't be too down on the fact that we're not supporting it. I think there are question marks. And you asked about the Gleason 7 things. The bottom line is it's a little bit more of a risk having active surveillance for a Gleason 7, but it's certainly reasonable in some people, but it requires careful patient selection. And at the moment, using MRI and biomarkers to try and work out whether you got a good or bad one is probably not the answer. There is some evidence that even using PSMA PET scan may help in this context. So if we then go to surgery, sorry about that, I'm just trying to move this stupid thing around. If we go to surgery then, the aim of surgery, that is removal, the total removal of the prostate and the attached seminal vesicle, a lot of people call it the trifecta, but I call it the pentafecta. So obviously you want to cure it, you want to be continent, and you want to be potent. But you also don't want any complications, and you also want a rapid recovery. So these are the ultimate aims of surgery. Surgery still is the gold standard, but there's no question that radiotherapy should be discussed with every case. The most important concept in surgery is that experience. The surgeon is the key difference, not the technology. So if you've got a very experienced open surgeon and a very inexperienced robotic surgeon, you definitely go with the experienced open surgeon. Experience is way more important than the technology. And a lot of people, there are some people out there who will argue, you know, where's the evidence that surgery even works at all? And I think, I mean, it seems a silly question, but it's not too silly, because if you really scour the literature, there's very few papers of what's called a level 1 evidence, a randomized controlled trial, that shows this. But the one that does show it probably best is the paper by Bill Axelson in the New England Journal of Medicine, where there was an 18-year follow-up. And what they did in this study many, many years ago in Sweden was did surgery or nothing for patients with prostate cancer. And if you take out the low-grade cancers, the Gleason 6s, there was a 40% chance of progression to death with surgery and an 87% chance of progression to death with monitoring it. So you halve the death rate if you took out the low-risk patients. Interestingly, the biggest difference was in the group of Gleason 7s, not 8, 9, and 10. But with 8, 9, and 10 these days, surgery alone is often insufficient, and it may have to be supplemented by follow-up radiotherapy, particularly if there's lymph glands, and it may have to be followed up by hormone therapy as well, and more recently, novel anti-androgens. Robot came in 2002. The first robot in New South Wales was the one I set up in 2006. The first robot in Australia was 2004 in Melbourne. There are now robots everywhere. They're not robots. They're a master slave. They're a piece of equipment that allows a surgeon to do laparoscopic keyhole surgery with better vision, with better magnification, and better instrumentation. There's been about 4 or 5 different iterations of this. The current most advanced model is the XI, which most people in Australia have. Just because you've got a better instrument doesn't mean you're doing better results. And I think it's really important that if we look very carefully at robot versus open and look at the various trials, some show there's lower positive surgical margins, some shows there's less complications, and there's less post-op radiotherapy. But in the only randomized controlled trial that was ever done in Queensland with John Yaxley and Jeff Coughlin, they were equal, apart from the fact that there was less side effects of the robot and a quicker recovery. The argument in that study was that Jeff at the time was a less experienced robotic surgeon than John Yaxley, who was the open surgeon. But that's quoted internationally. I think it's pretty obvious to me now, having done over 2,500 of these and having looked at many, many learning curves and trained many people, that robotic surgery in experienced hands is simply better now. And it's not massively better than a truly experienced open surgeon, but it is, because you see things you haven't seen before. You learn to use it after a pretty long learning curve. And once you're good at this, it's almost like a different operation.
I have a question for you. When is the single site robot SP going to come out? And is it going to be used for prostatectomies or only for kidney surgery?
So the single port prostatectomy, robot will first appear at St. Vincent's at our hospital. We've already paid for it. It's an incredibly long learning curve. It's very hard to use. It's a very different operation because everything moves in different ways and the clashes that occur are very different. So the learning curve needs to be taken in consideration. It's really fantastic for ENT surgery, which is why we're getting it, because one hole down the mouth is much, much easier than multiple holes in an open mouth. And that's where we'll be using it mainly. It is better for some kidney operations, particularly big fat people where you're trying to get difficult access, but there's never been shown to be any benefit in the prostate at this stage. And the benefit in terms of one hole and a reasonable size hole versus 6 holes is absolutely minimal. And the long learning curve would mean that a lot of patients are going to suffer a lot of side effects, which are totally unnecessary, because it still only gives you the same dexterity and instrumentation and vision. It's just that it's a slightly smaller hole. So that, in my view, is not going to take off in prostate.
Thank you.
But in ENT and in some kidney cases, I think it will be, and possibly in some very difficult rectal cases, it could be a game changer. So what I've learned from now, having done a lot of these and over 4,000 opens and 2,500 robots, you do have a quicker recovery. You have less blood loss. There are less complications. You do get better cancer control for the early cancers because you can see the prostate capsule clearer. You get an earlier and more complete return of potency and continence, but again, a long learning curve, and you have to be dedicated to improving. Some cases, such as obese patients, underslung pelvises or meshes, make robot much easier than the open technique. Personally, at the end of 3 open cases, I used to go home wrecked, but I don't anymore. The teaching in a robot is way easier, and the future potential using different technologies such as lasers and different injections and various forms of radioactivity findings with the robot, you can't do in the open technique. So I think it's here to stay. It is an advance, and I think in terms of shortening the learning curve on our trainees, it's an enormous advantage. But it is a long learning curve, and we wrote out our first learning curve a long time ago, 12 years ago. Now, you hear about a thing called nerve-sparing prostatectomy. What is that? Well, what it is, it's taking the cancer out and the little bit of extension and preserving the nerve bundle, which sits very close to the tumor. It's been shown, and I think before we go on to this in much detail, you've got to understand that the nerve is not a nerve. The nerve is a nerve bundle, 1 centimetre in diameter, with thousands of nerve fibres, scaffolding, arteries and veins. And the less you do to it, the better you are, because it's incredibly sensitive autonomic nerves. So it's not an all or nothing thing here. When you're trying to remove a tumour and it might be 1 or 2 millimetres outside of the shell and you're trying to clear it, but you're trying to do as little damage as possible to the neurovascular bundle, then the less damage you do, the better the chance of potency. So if a surgeon will say, on that side, I have to take the nerve, usually that means that he doesn't see the shades of grey, which is preserve 50%, preserve 75%, or there is so much cancer that he's absolutely correct. You have to take the whole thing. But it's not all or nothing. And what I can say is that if you do spare the nerves and you do it on a regular basis, then you're not compromising the cure rate. And this paper that we published 11 years ago in the British Journal showed that sparing nerves in experienced hands does not compromise cure. This was a paper by Vip Patel showing that on the left-hand side of the screen, if you take the whole nerve, which is the 0% plane, then you get no potency. But if you take half the nerve, you get 50% potency. If you take 3/4 of the nerve, you get 75%. And if you're sitting right on the edge of the prostate, you get 95% potency. Now, that's in Vip Patel's hands, who's done 14,000 of these cases. But I think it's important to understand that we're not all Vip Patel, but the principle of doing incremental nerve sparing is very important. Now, the surgeon should have a report card, and the patient should be able to ask the surgeon his report card. How many cancers which are contained to the prostate, so-called PT2, get residual cancer left behind? And that's a positive surgical margin. If the cancer is contained to the prostate and the surgeon's getting a lot of positive margins in that context, then he should really be looking to see how he can decrease that. The overall chance of getting a positive surgical margin, obviously, is there are some cases that it doesn't matter how wide you go, there's so much cancer that you can't clear it. Obviously, if 20% of your cases are Gleason 6 tumours, then you're over-operating on those people. And it should be a patient's right to know what percentage of your practice have got Gleason 6 tumours in it. Patients should be able to know what the major complication rate is. Patients should be able to know and the surgeon, what the early and late continence and early and late potency rates are. And most surgeons will allow their data of quality of life and positive margins to be tabulated by the New South Wales Institute or Cancer Registry, and they get a regular report from them. And I personally share mine with my patients. And I think if people don't allow the New South Wales Cancer Registry to have that data, I think that's telling something about the surgeon. I don't know whether, I don't know. I've got a video of protecting little nerves and things. I don't know if the audience are interested in that. What do you think?
Yeah, I think so. It's not, as long as it's not too long, it should be good.
Okay. So this is just, sometimes you'll find that if you look on the left of the scissors where I'm cutting, there's an artery there. And that artery is probably one of the major arteries that's feeding the penis. Not a nerve, but an artery. Now, we all think that potency needs to protect nerves, but it also needs to protect the blood supply of the prostate. And what I noticed is that when I started looking for these arteries and started protecting them, my potency rate went up. And so here we're protecting that artery. I apologize for the quality of the image, but it just shows that you can protect it even before you do the surgery.
Question while we're watching, can patients access the NSW data registry you were talking about?
Patients can't. And obviously this is a political thing as well. And a lot of surgeons give this data so that other people can't access their data. But if the surgeon is registered with them, he will have his data, and all the other data will be of the other surgeons in a de-identified way. So they'll just be a dot. We'll be able to will be given to the surgeon. So the patient, if they would go to him, could easily ask, do you subscribe to that? And if so, do you mind if you share your latest data with me? So here you can see there's two arteries at the front here, and there's the urethra at the back. So those two arteries are going straight to the penis. So if they hadn't have been spared, the patient would have been impotent, nothing to do with the erection nerves, only to do with arteries. Now, this is a very interesting video on the future of surgery. And you talked about the single port. This is a video of that single port. And if you can imagine, you're trying to control all these instruments coming out of the single hole rather than coming from separate holes. It's quite difficult. So the telescope is moving there, and then the scissors will start to move, and then the other instruments. And you can see it's pretty sexy, but you can imagine everything's pretty close together, and you can't sort of come at an angle, which sometimes is useful in the prostate. This is a study from the Sloan Kettering, and each one of those dots is a surgeon. And just to give you an idea, the size of the dot is the number of cases he does per year. The bottom line is the urinary function, and the top and the y-axis is the erectile functioning. And you can see even the top surgeons of the Sloan Kettering have enormously different potency and continence rates. I'll pass this one. This was too complex. Okay, external beam now. External beam has also undergone enormous changes. So conformal radiotherapy is now the standard of care, but these days they even have an ability to do radiotherapy inside an MRI machine called an MR-Linac radiotherapy. We've learned that irradiating the lymph glands is quite an important thing in certain patients where lymph glands are likely to be involved. We've also realized that the higher the dose to the prostate, the better the outcome. But also we've learned that if there's a particularly high-grade cancer in the prostate, that if you irradiate that to a very high degree, in other words, dose escalate that area, the results are much better also. The technology is getting better. These days we put space material in between the rectum and the prostate to avoid rectal damage, and we put marker seeds in. And so it's changing too. This is a typical VMAT machine. Typically it used to be 60 to 80 treatments. Now it's down to 40 to 20, and with the MR-Linac 5 treatments. The planning is much, much better these days because of the ability to focus these beams. So here, for example, they're increasing the dose to a very high level just in this little spot here on the lymph gland. Brachytherapy is also still popular, but low dose rate brachytherapy is becoming less popular because of the MR-Linac machine, because it's a quick treatment, the MR-Linac machine, like brachytherapy, and of course it's not putting seeds in. High dose rate brachytherapy is a boost of radiation for the really high grade cancers, and that's still being used, but in very select units. This here is the MR-Linac machine, and this is a radiotherapy inside the MRI machine, so you can real time see whether the rectum's moving into the field and then stop the treatment and then wait until the rectum moves out and the gas has passed.
I must say, it looks like something from the Star Trek Enterprise, Phil.
Well, that's a picture of our one.
Wow.
And so it's $10 million. It's expensive, but it's, you know, people start their treatment on Monday, finish their treatment the next Wednesday. They've had 5 treatments. It's all done and dusted, and with a lower side effect profile. Quite a remarkable advance.
Incredible.
I'll pass this one, pass that one. Okay, so then the next thing to consider is whether we could just treat the cancer. Given the fact we're now getting much better imaging with MRI and PSMA PET scanning and better biopsy techniques, we can localize cancer to, for example, in this case, to a tiny area on the right-hand side. And maybe then you could just treat it rather than the rest of the prostate. What we do know is that you have to go and a little bit wider than you think on the MRI. So you always have to take a centimetre safety margin. And, you know, in the old days, the low-risk cancers were treated with active surveillance, and the high-risk cancers, whole gland therapy. Maybe now the middle group, the focal therapy, could apply to the intermediate grade because they don't pose as much a risk and it still gives you the same type of result. Why do we need focal therapy? Well, we've learned that from all the trials that for Gleason 3 + 4 = 7, as you said, there's over-treatment happening. There's clearly less side effects of focal therapy compared to whole gland therapy, and it complements active surveillance, it's a little bit more, and it complements whole gland therapy, it's a little bit less. It's a much more risk stratified approach, and it's only appropriate for about 20% of unifocal lesions. And we've sort of learnt that there are some people who just have a localized abnormality and the rest of the prostate's normal. The big question, of course, is, are we able to select these people accurately? And with an MRI, the negative predictive value, which is sort of how often the MRI says everything's clear and there's nothing there, is between 90 and 97%. Let's take the worst figure. It misses 10% of cancers. Well, that's just not quite enough. But if we do a biopsy, a thorough biopsy with it as well as the MRI, so you decrease that 10% maybe down to 5%, well, then we're starting to look like you might be able to find the right people who've got Gleason 7 tumours to do focal therapy. The ideal candidate is just one lesion, typical, 72-year-old guy who refuses or is unsuitable for whole gland therapy. He's got intermediate risk disease. Maybe he's been on active surveillance and something just showed up and you just want to zap that and keep an eye on the rest of it. It can obviously be done in the primary situation, but it can also be done after radiotherapy's failed, but I'll leave that to another time. And the world consensus is that the PSA should be under 15 and it should be a Gleason 7. The technology that I started about 10 years ago is called irreversible electroporation, or the company calls it a nanoknife. It's a form of electricity to destroy this cancer. The reason I picked this over different heating and cooling techniques, and the heating techniques are HIFU or laser, and the cooling techniques are cryotherapy, is because it has some potential benefits. It causes a very reliable ablation, which isn't dependent on the nature of the tissue. It's a quick day surgery procedure. It's repeatable. It potentially can preserve structures because it's not using heat or cold, and salvage surgery is still possible. This is a typical example here where there's a tumor at the front of the prostate. And what I do is I put 2, 3, 4 electrodes in, and then whilst the patient's asleep, pass an electrical current between each of the different pairs until you've caused an ablation. And by doing that, what you effectively do is you destroy that area. It takes 40 minutes to do, and the person walks out as a day coach. So obviously the question is, well, what's the results? I've been recently lecturing on this around America, and bottom line is that we're getting 99% pad-free, so incontinence is not a problem, 5 to 10% chance of impotence. But the most important thing is that we're getting about a 96% chance of clearing the tumour. and about a 12% chance that a new tumour will show up in another part of the prostate with time. And obviously that mandates monitoring. We also found that even if you did have this treatment and then it failed and then you had surgery, the question was, did that surgery still cure you? And the answer was yes. In the 22 patients that we've taken the prostate out afterwards, all of them have remained clear of biochemical recurrence. And pretty well all of them are dry by 6 months. And radiotherapy is also possible after if it fails.
Can I ask, is PSA a reliable monitoring tool after the procedure?
It helps, but it's not reliable. The only thing that's reliable is imaging with MRI, and usually we do a biopsy at 12 months to make sure it's gone. If the PSA is going up, it's a prompt to further investigation, not a prompt to treat. Because obviously if you're leaving the prostate, the majority of the prostate alone, the majority of the prostate can still grow again, causing the PSA to rise.
Thanks.
So if we then go to some of the, so we're at 1.5 hours now. If we go then to the complications of treatment, one of the complications is incontinence. And treating incontinence may require pelvic floor exercises. There's a thing called a PROACT device, which I used to use a lot of, little balloons that go in, which are adjustable. And again, they can be used if necessary. They're not particularly popular, but about 2 or 3 of us in New South Wales put them in on a regular basis. Slings are well known for incontinence, for mild incontinence, and the artificial sphincter, of course, is a successful treatment for incontinence. This is the sling. The current popular sling is called an advanced sling. Patients are in overnight for this, and it immediately turns you from wet to dry. About 90% of people benefit from this. The PROACT device are little balloons that go in beside the bladder neck, which can be adjusted by little ports which are placed under the skin to compress the bladder neck. And the artificial sphincter has been around for a long time and has undergone some modifications and is an incredibly reliable and good option in severe incontinence. With regard to impotence, it's difficult to recommend any particular penile rehabilitation protocol with PDE1 at the present. What we recommend is that everybody after surgery or radiotherapy goes onto a low dose of a PDE5 inhibitor, such as Cialis or Viagra. We recommend a vacuum constriction device twice a week to prevent penile shortening, and then on-demand PDE5 if necessary. I think that there are better outcomes if the rehabilitation is started early. And if there's no improvement after 4 weeks, then I think we need to consider something like intracavernosal injections.
How early is early?
After the catheter is removed, usually day 6 or 7.
So they start treatment. Do you recommend sort of masturbation with the treatment at that time after the catheter comes out?
No, probably not for 4 weeks or so. I think that, you know, there's a healing phase that needs to happen there. I don't think it does any harm, but it could cause discomfort. So I tend to recommend, I mean, a gentle situation, sure, but nothing vigorous until 4 weeks.
Thank you.
And then in terms of injections, Cavaject, of course, is the standard, but generally going to a sexual health physician who is able to tailor you with a trimix or quad mix is much better, because Cavaject hurts you, prostaglandin hurts you, whereas you know, having a small dose of each of the different chemicals doesn't cause pain. Vacuum devices we're familiar with. Then, of course, as everything else fails, a penile implant. Over a career, I've done about 500 of these, but in terms of post-surgical ones, probably a couple of hundred. It's a very good option in highly selected patients where everything else has failed and they're very keen. but it shouldn't be a first-line treatment. Just to sort of catch up on a couple of other things now, changes in prostate cancer. As I mentioned before, PSMA PET scan, whilst it has an established role in a rising PSA post-radical prostatectomy or post-radiotherapy, it may actually aid in MRI screening. So this, we completed a trial recently called the primary trial, where we did PSA, and in patients with PSA elevation, we not only did an MRI before biopsy, but we also did a PSMA PET scan. What came out of that was that if the MRI is equivocal and the PSMA PET scan is clear, then there's only a 2% chance of a significant cancer. If the MRI is equivocal and the PSMA is positive, there's a 60% chance of cancer. So adding a PSMA PET scan could be very useful and cost-effective in decreasing the number of unnecessary biopsies, even beyond MRI. Now, that's work in progress. We're doing the primary 2 study to do a randomized trial to validate that. Interestingly, we won the prize for the best research paper in the world for primary 1 in Europe last year on the primary 1, which Louise accepted the prize.
Congratulations. Can you give an explanation why the PSA can rise after prostatectomy and the PSMA PET scan is negative, doesn't show any cancer?
Yeah, so a rising PSA post-prostatectomy is surprisingly common. It probably occurs in about 20% of patients. And some of them are harmless and some of them are dangerous. The harmless ones are the ones that occur many years afterwards. They go up incredibly slowly and the original pathology wasn't too bad. Those people are best counseled just to do nothing and keep an eye on it, because the natural history of that situation is benign. On the other hand, the ones that go up quickly with a quick doubling time, less than 2 years after surgery, when the original pathology was high grade, are a dangerous condition. Now, PSMA PET scanning looks for prostate cancer cells which express that chemical. And obviously the cancers that have spread from the prostate to wherever they are regrowing, either in the prostate bed, the lymph gland, or a bone, will express this chemical. So you would expect it to light up that area. The problem with PSMA PET scanning is that some cancers express PSMA to a very limited degree, and some cancers are too small to be picked up by PSMA. So what we learned in the study that we did was that the cancer in the lymph gland had to be at least 4 millimeters in size before it would pick it up. And we also learned that the cancers that occur in the prostate bed after a fairly low-grade tumour, such as a Gleason 6, don't express enough PSMA, so it doesn't pick it up. So what we do in terms of being practical, we wait until the PSA reaches 0.2, because we know that we've caused no harm by delaying till 0.4, and then do a PSMA PET scan then. And then use the PSMA PET scan to help guide therapy if therapy is necessary. Again, just because a PSMA PET scan picks something up doesn't mean it's necessary. Just means that you know where it is.
That's great. Thank you.
I said that. So here, for example, is a person with a PSA recurrence that you were just asking about, and there's a circled area with a red arrow to it, which shows a lymph gland with a recurrence in it. So that would be a very easy thing to target with radiotherapy and aim the radiotherapy at it, and in one fraction, kill it. Now, really advanced prostate cancer, spread to bone, spread to lymph glands, failed in traditional hormone therapy. There's been a lot of progress in this area too. And the PCFA have been very helpful in supporting some of the research into this group of people. So over the years, there's been the Provenge vaccine, which really is not a very effective and very expensive treatment. The chemotherapies, docetaxel and cabazitaxel, they've made a big difference. And the biggest difference has been made with the new tablets, what's called novel anti-androgens. The first one was abiraterone, then came apalutamide, then enzalutamide, and more recently darolutamide. And they've been shown that even in very advanced cases of prostate cancer, which have spread everywhere, they'll add an extra 2 years of life to that person. And if you're a good responder, considerably more. Obviously, as with time, they're bringing those medications earlier in their disease journey. And so in hormone-sensitive disease, they probably provide even a longer survival benefit. And, you know, that there'll obviously be trials soon in a post-surgical and post-radiotherapy context in high-risk situations to see if it works in that as well. Bone health is very important, and there are lots of new drugs like denosumab, which help stabilize the bone and prevent osteoporosis, which is a known side effect of the hormone therapy from getting worse. And more recently, the targeted radiation therapies, such as lutetium PSMA, and we're doing a trial at the moment on actinium PSMA, looking at whether we can put some of these patients with very advanced disease back in relative control. So there's been a lot of work in this. This is the realms of a medical oncologist, not a urologist, these things. Although as the novel anti-androgens percolate back into the earlier stages, we have to become familiar with them as well. So the new research, I haven't updated the number of 2020, it's 2022, is there is some response to immunotherapy in certain cases. There have been some work on giving testosterone back to some patients who are in the last stages. There is some evidence that adding dutasteride to abiraterone might help. There is evidence that in people with a BRCA abnormality, that a group of drugs called PARP inhibitors might help. Obviously, apalutamide, darolutamide, enzalutamide might help. Lutetium PSMA and actinium PSMA might help. Germline testing might help. We may be able to find a targeted growth factor which can treat that. And as time goes by, we need to understand why some cancers just go to sleep and some don't, the concept of dormancy. So this is just an example of how lutetium PSMA might work. This is a person with a bone scan with PSA 95, where every part of his body lights up like a Christmas tree. And all of those disappeared with one single dose of lutetium. Then, of course, as we reach, I'm getting towards the end now, so you don't have to go to sleep. Does diet really affect prostate cancer? And that's always been a question. We know that obesity is associated with a high incidence of aggressive prostate cancer. Selenium in Australia is deficient and might have a benefit, but the worldwide trial showed no benefit. Vitamin E, if you take it, actually increases the incidence of prostate cancer. Omega-3, unclear. Lycopenes, evidence is inconsistent. Mediterranean diet reduces the incidence of metabolic syndrome, but we're not sure whether it really decreases the chance of prostate cancer. So as you can see, the only thing that really lights up here is obesity. Exercise. If exercise were a tablet, we would think that we've got a magic potion. The application of specific exercise for patients not only prolong their life, improve their quality of life, decrease their cardiovascular problems, especially those on ADT, it's almost an essential part of their journey in prostate cancer, both resistance and aerobic exercise. And I think the PCFA urology nurses are very mindful of that and make sure that it becomes a habit in all patients with prostate cancer. Meditation. Now we're starting to get really, off the beaten track. Meditation has Buddhist origins, as you know. It's increasingly used in people with prostate cancer. It's increasingly been shown to improve T cell function. It reduces pain. It improves sleep and mood. And that whole concept of managing your mind while you're going through this journey is so important, and I think is underplayed in many of our conventional systems. Interestingly, the Cleveland Clinic has a mindfulness clinic right beside the Prostate Cancer Center. So in summary then, I think the future is screening with PSA and MRI and PSMA, better imaging with PET scan, MRI, and new antibodies which are yet to be developed, personalized genomic profiling, image-guided surgery, targeted radiation with the MR-Linac, focal therapy, bringing new anti-androgens or novel anti-androgens and immune therapy, maybe in combination, into an earlier stage, theranostics with lutetium and actinium, and then the combinations of various of these therapies. And so whilst it's impossible, as you know, to go through this whole section, I hope that's given you some insight into where we are in 2022. And thanks for your attention.
No, Phil, thank you. That is absolutely incredible. When you said you had 100 slides, I was like, how is he going to get through all of them? And you managed just fine. It's, yeah, we're so lucky to honestly have your expertise, your knowledge, your wisdom, and share that with us here today. And for taking time, away from spending with your family and your grandkids. You said you were looking after them.
It's okay. He's right next to me. He's been listening to it. He's been learning.
Oh, yeah. Okay. Future urologist in training. That's great. Have a few questions here for you. Firstly, excellent presentation, and what a sensible approach to prostate cancer treatment. I would agree, not specifically forcing and pushing one particular treatment, which is really good. Is the Linac used for anything else other than prostate cancer?
Yeah. Yes. So it's used for anything where you want to where you can accurately see it real time and where movement could potentially affect it. For example, we recently had a person with a secondary from prostate in their lung, and it was right next to the heart, and we needed to ablate it at high dose without damaging the heart. The heart's pumping all the time. So if you can sort of do it and sort of regulate it to the heartbeat, you can actually, without any damage to the heart, actually treat it. And that applies to, it's used in every part of the body. It's not a revolution, but it's a major advance.
Oh, that's good news to know that the $10 million wasn't only for prostate cancer. The another question, is there a specific exercise? You mentioned exercise, and I know exercise physiologists, that's their domain, but you probably have some idea about the specific types of exercise.
So we wrote a paper a long time ago with a guy called Nelson over in Perth, who you probably have had on your group, and
Yes.
as a review of exercise in prostate cancer. And that review showed that a combination of resistance and aerobic exercise are critical. And so as you know, with hormone therapy, you get sarcopenia or loss of muscle mass. And if you don't address that with exercise, you never get it back again. And so it's important from an early stage to be doing guided and low weights. You don't want to have injuries, but you should do weight training under the supervision of a trainer. And a lot of the drug companies will offer nurses to actually teach people to do that. The second thing is aerobic exercise. Weights aren't enough. If you don't get aerobic fitness, then you put yourself at risk of your cardiovascular risk factors. So again, it doesn't have to be too much. 20 minutes 3 times a week is the minimum, but that should be probably incorporated as well. Now, exactly what that aerobic exercise is and whether it's interval training or not interval seems to be the best way to get aerobic fitness is probably important, but that's in the realms of an exercise physiologist or nurses who actually have expertise in that.
Yeah, I agree. And we have, if you go back to our previous webinars, we have actually had exercise physiologists go into that in quite some detail. Phil, there's a question. Is it true that lutetium doesn't work for people with BRCA mutations?
No, that's not true. I think the people with BRCA mutations are more likely to have anaplastic tumours which don't secrete PSMA, but equally, you will sometimes see a lot of PSMA secretion with BRCA. So it may be something that slightly decreases the chance of you expressing PSMA, but it doesn't exclude them.
Yeah, that makes sense. There's one last question. Do you recommend that patients access a multidisciplinary high-skilled team like you have at St. Vincent's if the urologist doesn't recommend it? Can they override their urologist?
I think every urologist in Australia has access to an MDT meeting if they're attached to a hospital. And so it's not very hard to say, well, if the patient said, do you mind presenting to your MDT meeting? Then the urologist will say, okay, well, I'm in Griffith, I'll present it to the Griffith MDT meeting. And they all have to have it. They're not compliant otherwise. And so I think that they all have it. They might not have it in their private practice, but the hospital will have it.
What about the little add-on extras like the sexual health practitioner that you mentioned and the specialist nurse and that sort of thing?
I think I described the ideal world. The ideal world doesn't exist everywhere, certainly doesn't exist in country Australia. And so I think a sexual health physician is probably rare in that situation. It's more common in capital cities. And in terms of, but having said that, I think the role of the prostate cancer nurse does get expertise in exactly that area and can be doubled up for doing that. And I think, and I bend down to our expert who's been listening as to whether they are able to cover that area. I'm pretty sure they are.
Yeah, I'm actually going to give her one more chance to just conclude with the services that are available at the PCFA. But first, I want to thank you, and I want to also get just read to you some of the thanks from the audience. Thanks for an interesting presentation. Very informative, very unbiased. So informative, I'll use it for my next support group meeting. So thanks to you and thanks to the organizers for what we've done. And thank you for honestly supporting us. This has been your second session with us this year, and we hope that you will continue to be a regular feature of these ongoing webinars that we plan to continue. I think this is just such a good opportunity for patients to get educated and informed. And it's nice that they want to, you know, and become the experts of their cancer journey. So thank you. Anne, if you're there, do you want to just tell us in summary what about PCFA services available?
And thank you, Kalli.
Thank you.
And thanks, Gary.
Yes, Gary's going to come on and close the session for us. And if you want to, you've got 2 minutes to let us know what's available. Thank you.
And thank you from me too, Philip, Kelly, and Gary. It's been wonderful. As I mentioned before, we do have a telenursing service. We've got a no-cost cancer counselling service, and we have 43% of our nurses are actually in regional areas of Australia, Philip, and that's based on need and demand, as you've correctly pointed out. Then when we were talking earlier about transperineal versus transrectal, you do tend to see transrectal still being preferred in regional areas because of the exact problem that you pointed out, and we're hoping to see that change. I guess I'll just finish with one more point, which is that we hope that the really transformative move in prostate cancer care in Australia will be this review of the guidelines. We are hoping that even though it's directly out of scope to make broad recommendations that things such as surgical treatment for erectile dysfunction and incontinence needs to be listed by the Australian government and prioritised for men with prostate cancer. So we plan to use the review as an opportunity to increase and strengthen our advocacy. We're very grateful for everyone's support for that, and particularly PCFA's Prostate Cancer Support Group Network and the work of people like Gary and Kalli in doing what you do every day. So thank you all.
Thank you, Anne, and thank you for your support. We couldn't do this without you. And over to you, Gary, for the final conclusion.
Thank you very much. Philip, thank you so much for your presentation. I've got to declare a bit of biased interest here. I mean, Phil was my surgeon going back 14 years ago now. What's been interesting throughout your whole presentation is I can remember being in your clinical trial with MRI going way back, and to see the advances of that now is just absolutely extraordinary. I'm a success case, so I've come out the other end brilliantly, and 14 years on. So that's one of my first observations. The other one is your book that you're planning to bring out next year. I'll be really fascinated about that, because I think the title, and I think you said the word regret was in there, to have no regrets, is going to be just so helpful, because just even with our support group that we run, going through that initial journey of diagnosis and how to work out treatment pathways and what have you, and not having any regrets at the end of making your choice in the direction that you're going to take your treatment, I think is absolutely paramount in the journey and the development of treatment of prostate cancer into the future. Can you expand a little bit more on just what your book is going to be about in total?
Yeah, so the book I'm writing at the moment is about what I call the 9 personality types. And over a 30-year practice, I've learned that the most important factor in patient-doctor communication is not their condition, not their biases, but their actual personality. Yeah. And if you don't take into consideration both sides of the equation, if the patient doesn't have insight into their personality, and if the doctor doesn't recognize the personality type, the chance of regret is much, much higher. So my aim is to take those 9 personality types, and obviously not everybody's 100% one, but take them, get people to recognize them, and also understand what's necessary for them to be comfortable with their decision. I'll give you just one example, otherwise we're going to go way over time. So one example is what I call the physicist. The physicist is a person who comes into my office with a stack of internet information and peer-reviewed information that can actually, he can't see you over the stack of notes that have come over the paper thing. He says, "Doctor, we need to go through each and every one of these things." So my immediate reaction to that is, I'm going to have 4 one-hour sessions with this person. The first 1 hour session will be only listening. I will not do anything but listen. And then gradually, with time, we'll go through the information. He'll come to the same conclusion as I would have told him right at the beginning, but there will be no regret at the end of the journey, because he will have participated in the way his personality needs to participate to get to a good outcome. That's just one example. I'm trying to introduce humor into it, because there are incredibly funny moments to do with all of these patients. The classic one was what's called the paternalistic patient. And this is a highly controversial patient, because a paternalistic patient is a person who does not want to participate in the decision. Now, that's not 2022 compatible, but they're real. And they don't want to go away with a book. They don't want to speak to 1 million people. They think that they got a good person. They want you to put themselves in their thing. They're paying you a good amount, and they want you to give a recommendation. You can't change the personality of that person. But what they do for insurance, which I thought was pretty funny, you know, the guy from Griffith, who's part of the mafia, comes in with his wife. His wife doesn't say anything. His 2 children do all the talking for him. He doesn't do any talking. He just stares you in the eyes. But he takes a gun out of his pocket and puts it on the table and just says, do you mind if I just leave that here? It's a bit uncomfortable. What he's really saying is that this is my insurance and this is my security. So there's a lot of individual situations like that, which will make it very humorous.
Yeah.
But the problem is you can't change people. And you got to address the fact that that's the nature of that person. And if he wants you to make a decision for you, I make a decision for him, but I do my best to try and put myself in their shoes first. Now, that's highly controversial because everybody says, it's a shared decision and all this type of thing. Well, for some people, it's not. I mean, it is, but you have to listen to the person.
Yeah. No, and it's going to be a must read.
Looking forward to it. Gary, just a quick one. Someone in the audience had mentioned that, maybe for a solution to the rural problem and is something like today where we can use Zoom and, video conferencing to educate and inform and do sessions and give advice to people living in rural areas. And maybe that's something that PCFA can also work on if they're not already.
But Kalli, it doesn't put a piece of equipment and expertise in rural Australia.
True. Yes, that's true. We need to multiply you.
No, you don't. You just have to, hospitals have to say, well, this is an important piece of equipment. And, once the equipment's there and it's easy for the urologist to use, then he'll use it.
Yeah.
So true. I'd like to, at this stage, and I know I'm conscious of time and to wrap up, I would like to end our final webinar here today by thanking Phillips so much for your presentation today. It's been absolutely first class. I'd also like to thank our sponsors, Boston Scientific and also PCFA. This year wouldn't have happened without their support. And the great news is that we'll be back next year. So we've got Boston Scientific back on board, and we've also got the support of PCFA. Thank you to them. And lastly, thank you to all of you who have attended our webinars during the year. It's been a trial year for us. We're going to step it up next year, I can assure you, in production and what have you. And I really look forward to be presenting this. Kalli and I are going to look forward to presenting this again to you in 2023. On behalf of Kalli, I wish you all a very merry Christmas and a safe Christmas. And if you're having a holiday break, come back refreshed and don't let COVID get you. Take care.
Thank you. Thanks all.
Thanks, Phil.
Cheers.
Bye.